Hello, I am Dr. Anne-Marie Kimbell, National Senior Clinical Consultant with Pearson Assessments. I want to welcome you to this brief introduction to RehaCom, Computer-Aided Cognitive Rehabilitation, created by Ferry Tomasic, RehaCom Consultant for Hazamed GmbH, the company that developed RehaCom. Cognitive rehabilitation therapy uses a number of different methods, including individualized clinical therapeutic interactions, as well as computerized interventions. The cognitive rehabilitation therapy team may include neuropsychologists, psychologists, occupational therapists, speech-language pathologists, psychiatrists, and other clinical rehabilitation medicine specialists. The goal is to help improve an individual's ability to function after a brain injury or other neurological event such as a stroke. We want everyone involved in brain injury rehabilitation in the United States to know and trust RehaCom, the premier software for professionals working in the field. The primary goal of cognitive rehabilitation is to ameliorate injury, degenerative, or inflammation-related deficits in order to maximize daily functioning, independence, and quality of life. Progress is achieved in a stepwise manner, including comprehensive assessment, rehabilitation planning, and an individualized treatment. Rehabilitation of cognitive impairments includes a variety of approaches. Computer-based intervention should be considered as an adjunct to clinician-guided treatment for the remediation. If you are looking for the most effective care for your clients, we are convinced you will like the evidence-based and clinically proven RehaCom system. RehaCom provides deficit-specific, highly effective computer-assisted therapy for patients with cognitive deficits resulting from stroke, TBI, inflammatory and degenerative diseases, or associated with psychiatric diseases. Based on the science of neuroplasticity, it targets both restorative and compensatory training for identified areas of cognitive weakness. RehaCom has 28 precisely refined training modules to address very specific cognitive deficits, including those dealing with detailed aspects of attention, memory, executive function, and visual field issues. This precise ability to tailor the training to the patient's needs is important to success. RehaCom's interventions involve two basic approaches, that is, direct restoration and compensation strategy training. Both approaches are used simultaneously in best practice rehabilitation. Direct restoration is believed to be associated with the restitution and restoration of function via reconnection of pathways. This approach is based on the assumption that damaged neural circuits can be retrained if they have been partially or substantially spared after injury. In direct restoration, the effect of the deficit following injury is reduced through systematic exposure to specific cognitive activities targeting specific neural processes. Computer-aided therapy methods that train specific attention domains in situations close to everyday life have been shown to be particularly effective. High training intensity and frequency are required. This is exactly where RehaCom is designed to help. The compensatory approach plays an essential role in treating memory, executive functions, and visual field deficits. The basic idea is to teach ways of bypassing or compensating for impaired function. A key element is the memory strategy training. Internalized strategy utilization is based on explicit memory and self-instructional routines learned through cognitive training. Scientific studies and clinical practice have shown positive results and therapeutic efficacy in the following patient groups: stroke and traumatic brain injury, mental health, particularly with schizophrenia, depression, addiction disease, and auditory hallucinations, inflammatory and degenerative diseases such as multiple sclerosis and mild dementia, childhood developmental disorders such as ADHD, and geriatrics. Cognitive impairment is also one of the consequences of severe and critical forms of COVID-19 in many survivors. A meaningful proportion of patients show memory, attention, and executive function deficits at discharge from ICU. Computer-aided cognitive therapy with RehaCom can make an important contribution. According to Johns Hopkins University neuroscientist Majid Fatouhi, brain rehabilitation is crucial for restoring patients' cognitive abilities after they experience neurological complications like stroke. Dr. Fatouhi said, if someone has weakness in their left arm and they don't use their left arm as much, it's not going to get stronger if they don't receive physical therapy. The same happens in the brain. People need to receive brain rehabilitation in order to recover from COVID-19 symptoms. RehaCom is by far the most comprehensive system for computer-aided cognitive rehabilitation. The system provides 9 screening modules. Using RehaCom's built-in screening modules gives a rapid assessment of the client's deficits compared with norms from a group matched by age and gender, and then the software suggests which training procedures to use. While not a substitute for a full assessment, screening means that targeted rehabilitation can commence without delay. 28 computerized therapy modules are available to help your patients improve cognitive function and compensatory skills. 13 attention modules, 7 memory modules, 3 executive function, and 4 visual field therapy modules, plus 1 module for visual motor skills are provided. Each module can be seen as a separate large training program. If required, you can fine-tune the many parameters to enhance training for your patient. For this reason, each module is equipped with a separate parameter menu. This menu shows all the parameters that can be adapted depending on the goal of the therapy module. Often the kind and speed of automatic adaptation can be adjusted, and in most therapies, the therapist can also decide how the patient should operate the training, for example, if they should use the keyboard, mouse, or touch screen. Sometimes the working speed of the patient can be adapted. In other modules, special aspects of therapy can be highlighted. The variety of adaptation is nearly endless, but these parameter adjustments are optional and not necessary in order to get started. You may use the default settings if you wish. RehaCom was developed by well-known experts and therapists in Germany with more than 30 years of experience. The sophisticated system has been used and refined since the late 1980s in German-speaking countries and is now used around the world. It is by far Europe's leading system for computer-aided cognitive rehabilitation. Over the past 5 years, RehaCom has established itself with therapists across the United States and has become an indispensable therapeutic approach. RehaCom is a tool to make both the therapy and the therapist more efficient and effective. This is an example of how technology can be used to great effect. It streamlines, facilitates, and amplifies what the therapist is able to do. Freeing the therapist from some routine tasks allows them to step back and see therapy in a different way, coaching the client and implementing strategies that blend the best approaches while tracking performance. As mentioned, leading researchers in the field of cognitive rehabilitation have been developing RehaCom for more than 30 years. There is strong scientific evidence that this system is successful in the treatment of cognitive deficits. Numerous studies have shown the efficacy and feasibility of the program. There are approximately 70 scientific studies of patients with TBI, stroke, ADHD, MS, mild dementia, schizophrenia, auditory hallucinations, depression, and addiction disease. The Cognitive Rehab Task Force of the American Congress of Rehabilitation Medicine, or ACRM, conducted a meta-analysis of 121 systematically reviewed studies of cognitive rehab for people with TBI and stroke. 41 were rated as Class 1, 3 as Class 1A, 14 as Class 2, and 63 as Class 3. Articles were assigned to one of 6 possible categories based on interventions for attention, vision and neglect, language and communication skills, memory, executive function, or comprehensive integrated interventions. Their overall analysis indicates that cognitive rehab is of significant benefit when compared with some alternative treatments. The task force made 29 recommendations for evidence-based practice of cognitive rehabilitation. Evidence supports practice standards for attention deficits after TBI or stroke, visual scanning for neglect after right hemisphere stroke, compensatory strategies for mild memory deficits, language deficits after left hemisphere stroke, social communication deficits after TBI, metacognitive strategy training for deficits in executive functioning, and comprehensive holistic neuropsychological rehabilitation to reduce cognitive and functional disability after TBI or stroke. RehaCom specifically has been studied as well. 2 of the most encouraging and rigorous studies utilizing RehaCom demonstrated not only the effectiveness of computerized cognitive rehabilitation overall, but specific effectiveness in memory and in executive functioning. The studies found increased connectivity in cerebral functional connectivity of the hippocampus with frontal and parietal cortical areas, and improvements in attention and new learning. In addition, working memory training resulted in significant improvements on working memory, word fluency, and prospective memory performance. So both a direct benefit and a generalization of training effects have been indicated. I want to point out that these types of cognitive deficits are common after stroke or TBI. Up to 80% of stroke and TBI patients suffer from attention deficits, up to 60% from a loss of memory. Up to 30% have visual field limitations, and about 75% suffer from executive functioning limitations. RehaCom can be used through all stages of rehabilitation, from severe to mild deficits. The easiest training levels can be used at the acute stage, becoming progressively more challenging as it auto-adapts to the user's ability. Moderate levels, up to very challenging levels, are appropriate in a post-acute phase in an in-clinic, outpatient, and/or home-based setting. In each training module, the user is presented with tasks that will automatically adjust what the user sees and hears based on their actual real-time performance. This ensures that the user is always working at the optimal level of challenge in each task. Motivation is supported, boredom and frustration are less likely to occur. There are no negative stimuli to destroy confidence and morale. Each training module is extremely rich in the variety and depth of content. It would be simply impossible to provide the same level of content with paper-based methods. It's not necessary to guide the patient all the time. RehaCom leads the patient, instructs, and gives feedback. The patient progress is automatically tracked. As the clinician is able to provide services to a larger number of clients, his efficiency also increases. The reporting of performance is highly detailed and documents each user's activity and trends. You will easily know and understand the results. The therapist can fine-tune the performance of each training module if necessary after reviewing the results, and may vary the degree to which instruction is given. Here you can see all the modules that are available for both screening and therapy. We will take a look at the therapy modules now and the screenings at a later point. First, the attention therapy modules. When you concentrate on something, your brain has to process a great deal of information coming in from the world around you. A brain injury can affect the brain's ability to do this. A patient may not be able to stay focused on a single task, filter out what's going on around them, move from one task to another very easily, do more than one thing at once, or process information very quickly. RehaCom provides 13 attention modules. This large number of modules is necessary because attention deficits are common after stroke and TBI and are often found in degenerative and other diseases. As you know, a good working attention level is the foundation for all continued cognitive therapy. Even more, attention is a multidimensional cognitive function. We know from decades of research that specific attention deficits require specific cognitive training, and the training needs to follow a hierarchical organization. RehaCom includes 9 components of attention: alertness, vigilance, sustained attention, processing speed, focused attention, selective attention, divided attention, alternating attention, and visual-spatial attention. The modules you see here fully reflect these dimensions. It is important to provide repeated stimulation and activation of the foundational underlying attention dimensions at first. Even if the patient evidences memory deficits, for example, this impairment can be due to an attention deficit. As soon as a patient has mastered a foundational underlying process at a basic level, you can choose a therapy module to train higher-level skills. Next, the memory therapy modules. Patients often struggle with memory problems too, and this can lead to difficulties in everyday life. We store all kinds of information in our memory. We also remember things in different ways and for different lengths of time. Rehab patients may have difficulty forming new memories, whereas they can be very good about remembering things in the past. They may have difficulties with their prospective memory too, the ability to remember to carry out intended actions in the future, like remembering to take medication in the evening. Information encoding, storage, or retrieval can be impaired. Memory trainings with RehaCom reinforce learning strategies and help to establish compensation techniques. The system offers 6 memory modules: strategy, verbal, figural, topological, physiognomic, and naming content. They are close to everyday life, rich in variety, and the complexity adapts automatically to the actual performance. Working memory is a critical and limiting factor for cognitive control and executive functions. The module Working Memory supports both the storage and the manipulation components of working memory and increasingly involves selective attention and inhibitory processes at the same time. The functionality of the working memory provides a basis for many higher cognitive functions such as problem solving, speech comprehension, arithmetic, and intelligence achievements. Turning to the executive functioning modules, many higher-order complex thinking processes happen without us being aware of them. known as automatic processes. Together, many of these automatic processes are known as executive function. Executive functioning includes all the things that allow us to organize, make decisions, and solve problems. It involves the way we monitor what's going on around us and adjust what we think and do in response to it. Signs that may indicate executive functioning disorders are not being able to manage time well, difficulty meeting goals, difficulty determining the amount of time necessary to complete a task, difficulty in organizing and planning, trouble switching focus and shifting between activities, and difficulty prioritizing work or responsibilities. Therapists are provided with 3 executive function modules with close to everyday life templates in order to train and strengthen logical reasoning, to practice shopping, and to train a complex vacation planning. Supported by the therapist, the patient has to identify and consider solution-relevant information, develop precise approaches to the solution, plan and analyze the approach to the solution in parts, recognize mistakes and steps that are not effective, correct errors, and develop alternative approaches to the solution. Finally, the visual field trainings. Visual impairment is a common finding after stroke and can have negative implications on quality of life and activities of daily living. With a visual field loss, you are unable to see a section of your field of vision, usually because the vision areas of your brain have been damaged by the stroke. The eyes themselves work normally, but the brain can't process the images from one area of vision. The most common type of vision loss is homonymous hemianopia, the loss of one half of the visual field in each eye. You may feel like you are unable to see out of one eye, but in fact both eyes are affected. When reading, words and sentences disappear when in the missing visual field. People may appear to have only half a face. Other types are loss of a quarter of the visual field, the quadrantanopia, loss of central vision, or random areas of visual loss, scotomas. There is a considerable amount of evidence that patients can be supported to compensate and adapt to visual field loss following stroke using a range of strategies and methods. RehaCom provides systematic adaptive exploration exercises, saccadic eye movement, searching missing numbers, identifying shapes, searching and counting objects, and reestablishing assigned perceptual functions by intense light stimuli. Some of the modules, such as Exploration, Exploration 2, and Saccadic training, are valuable for patients with a visual spatial neglect also. Visual spatial neglect is a common attentional disorder resulting from unilateral hemisphere damage, most commonly from a stroke. Patients with neglect pay no attention to the space on the opposite side to their injury. Many patients recover spontaneously, but in approximately 40% of patients, symptoms persist. Visual scanning therapy is widely used in rehabilitating patients with neglect. It mainly involves encouraging them to explore neglected side of space, often with the help of visual cues. The trainings enable the therapist to implement visual exploration and visual scanning training, inclusive of optokinetic stimulation. RehaCom also provides you with a visual motor coordination training. The training works on the basis of the tracking task. The patient has to follow a given movement by using the mouse. Through the training tasks, whereby motions always recur, the patient is encouraged to anticipate individual patterns of movement. This next short video will briefly show as an example the therapy module Divided Attention. This example shows how to train the ability to respond simultaneously to multiple tasks or multiple task demands.
The RehaCom module Divided Attention 2 trains the division of attention between visual and auditive modalities. This ability enables us to consciously pay attention to 2 different aspects without neglecting one of them. Training with this module is indicated for patients with neurological diseases such as stroke, traumatic brain injury, brain tumour, mostly in the frontal lobe, morbus Parkinson's, and multiple sclerosis, as well as for patients with psychiatric, gerontopsychiatric and other diseases such as depression, schizophrenia, addiction diseases, and attention impairments in child and adulthood. The divided attention is a complex attention function. A stable alertness function is a precondition for this training. Patients with severely impaired divided attention should start the therapy with the RehaCom module Divided Attention 1. Before starting the training module, it is possible to individualize the training parameters. Via the Therapist menu, one can adjust the level of difficulty, duration of the session, instructions, help, or stressors according to the patient's needs. It is possible to change these parameters at any time during the training. The task in this module is to drive the car a certain distance within a given time frame. Whilst doing so, the street, the environment, and the dashboard have to be observed in order to react to certain stimuli. The auditive and visual stimuli will often be presented at the same time and therefore need differentiated reactions. The training begins with a low number of different visual stimuli. With rising difficulty, the number and size of stimuli will increase. In higher levels, different auditive stimuli will be presented.
On the M5 to the west of Birmingham in both directions between Junction 3 at Halesowen and Junction 4 at Bromsgrove.
As difficulty increases, the duration and frequency of stimuli will become shorter and faster. For high-performance patients, an additional visual stimulus can be switched on in the form of a rear-view mirror. RehaCom works auto-adaptively. The difficulty level will rise or fall depending on the patient's performance. With each change in level, the user will receive additional feedback. At the end of a training session, RehaCom will create an evaluation graph. Training results will always be saved automatically. The patient will then continue from this stage when starting the next training session. Please find further information on our website.
Now we will look at the screening modules. As mentioned, screenings do not provide definitive comprehensive diagnoses, so cognitive screening tests should not be used as a replacement for comprehensive neuropsychological testing. But it is common for clinicians to be uncertain as to whether a patient is demonstrating behaviors that suggest cognitive impairment. It is important to quickly assess which of these patients are actually demonstrating cognitive impairments that may be contributing to functional problems. Screenings are also commonly used for the early identification of individuals at potential risk for conditions or disorders. They may indicate need for further evaluation or intervention. They are also used to monitor progression of symptoms or response to intervention. RehaCom has 9 screening modules on board. All screening modules deliver normative data in order to compare the patient's results with data of healthy persons of same age and gender. The screenings indicate the deviation from the norm value. Each screening has its own specific minimum duration corresponding to the respective test goal. The screenings last between 4 and 15 minutes on average. The screenings assist the therapist to find the right therapy modules. They can detect which cognitive deficit the patient may have and the degree of severity of impairment. As a result, the system recommends therapy modules most suitable for treating the client's specific cognitive deficits. Screening results are displayed graphically along a bar chart. A bar running to the left indicates the performance is lower than the average of that of the normative sample. The further the bar goes to the left, the worse the performance of the patient. Each color behind the bar represents the amount of deviation from the average of the norm. Red indicates a severe deficit. The deviation from the average of the norm is greater than 2 standard deviations. Yellow indicates a mild or moderate deficit. Deviation from the norm is greater than 1 standard deviation. And green is a result in the normal range. The distance from the average is smaller than 1 standard deviation or better. Screening results are summarized to the left of the graph in the discussion section. The screening module and test are shown, along with the screening date and a summary of the results. The recommended therapy modules following this screening result are shown boldly written at the bottom. You can see how easy it is to use RehaCom. You are able to provide a therapy session in only 5 steps, beginning with assessment and/or RehaCom screening, then begin the training with a module the patient can handle easily, which is resource-oriented and motivating, and then you will add therapy modules recommended by screenings to treat the more severe deficits, hierarchically and deficit-oriented. RehaCom adapts automatically to the patient's performance by providing level changes as needed, and all results are saved automatically, allowing you to quickly evaluate your patient's training results and provide strategy mediation. Every patient, even with severe cognitive or motor deficits, can be treated with RehaCom. Each therapy module is optimized to be used with the RehaCom patient's keyboard or panel. This special keyboard is large, robust, and has color-coded big buttons, and it is easy to handle and to understand. RehaCom lends itself to many care delivery situations, and this is important for both cost-effectiveness and convenience. The software can run on a therapist's computer in the clinic or can be implemented in an existing clinic network over local area or wide area networks for multiple station licenses. As a therapist, it is also possible to use RehaCom as a telepractice solution. With this method of delivery, home-based therapy is prescribed to the patient by the clinician responsible for the patient's cognitive rehabilitation. The therapy prescription is assigned from the clinician's computer and is transferred over the internet to the patient's computer at home. The patient can then launch and complete their training using special patient-specific software loaded on their home computer. Completed training results are then downloaded by the clinician to their computer for monitoring and therapeutic evaluation. In summary, RehaCom can be tailored to the needs of each patient and is characterized by fundamental benefits. It is structured, systematic, goal-directed, individualized, contextualized, and repetitive. Before closing, I want to share a couple of testimonials from clinicians who are using RehaCom. Julia Martin, occupational therapist and case manager at the Neurotransitional Center at Baylor Scott & White Institute for Rehabilitation in Dallas, Texas, says, "I work in a post-acute inpatient neurotransitional program where nearly all of our patients have an acquired brain injury. We have patients at all levels of recovery, and we have found that RehaCom is useful for nearly everyone as it can meet the patient at their current level and progress them appropriately. We use RehaCom to address the foundations of cognitive recovery for some and target more advanced skills for return to work and driving with others. The objective data RehaCom provides is a great tool for our clinicians to not just track progress, but use as a tool to show our patients their level of performance, especially when many of them have limited insight into their impairments. RehaCom has been a great addition to our program in many ways. Many of our patients enjoy it so much that they have asked if they can be given RehaCom homework for evenings and weekends." Reagan Adams, Director of Psychology at the Shrink Company in Australia, says, "As a clinical psychologist in a busy private practice, I have been using RehaCom for a number of months now with a particular focus on persons diagnosed with schizophrenia. We have found that RehaCom has provided our clients with a versatile, user-friendly cognitive remediation program that creates an individualized, tailored experience that targets each client's specific cognitive deficits. The screening modules are easy to run, and the results section provides both the therapist and the client with a number of visual aids to prompt and motivate. As the Shrink Company operates within a multidisciplinary team, RehaCom has acted as a crucial adjunct therapy to our nursing, psychiatry, and psychology approaches. Most importantly, RehaCom has facilitated the Shrink Company's objectives in translating therapeutic approaches that optimize the functional outcomes for our clients." I want to thank you for your time. If you would like additional information about RehaCom, please visit the RehaCom webpage at www.pearsonassessments.com/RehaCom or email us at rehacominfo@pearson.com.